Welcome to these roundtable discussions at EACTS 2012 in Barcelona. My name's Joel Dunning. I'm an editor at CTSnet and also a surgeon from Middlesbrough in the UK. These roundtable discussions are a new format that CTSnet have brought in together with EACTS, the STS and the EACTS. And we're delighted to be here with three of the foremost experts in aortic and mitral valve repair and replacement. Today is the Techno College, and our subject today is aortic and mitral valve replacement. I'm joined with three people that have both presented here. I have Vinod Thorani, an associate professor at Emory at Atlanta. He's just presented on transapical closure devices, including the Apica device, which he helped to create. We have Professor Hugo van Ermen. He's the founder and head of cardiovascular surgery at OLV in Aalst. He's known to all of us as one of the greatest pioneers of port access mitral valve surgery, and actually created Techno College and has had many videos and also live in a box sessions with us here. And also we have Hendrik Trieder. You're from the University Heart Center in Hamburg, and you've just chaired the session this morning on aortic valve replacement, and you have much experience in the new second-generation valves, including the Jena valve and many others. So perhaps if I could start by asking you, Hendrik, we're moving on into a new era of second-generation valves. What's out there, what's new, and what difference is it going to make for us all?
Yeah, we see a lot of new generation devices right now. Two of them are already released to the market. That is the Symetis device and the Jena valve. And there's a third player in the field who just applies now for CE mark. This is the Medtronic Engager valve. What strikes me most with all these new devices is that with all of them we see a terrific reduction in peripheral leakage. That is a great thing to achieve because we know now from the study data from the big trials, the partner trial, also from SURS, that peripheral leakage has a disastrous effect on long-term survival. And since we now have new devices of the next generation that are able to solve that problem, we are really one step forward.
And Vinod, we talked a lot this morning about different ways to put the valves in. There was a lot of discussion about transapical versus transaortic. What way do you think that the tables are turning at the moment?
Well, it's interesting. In the United States, as you know, it's a little bit different. We're a little behind compared to our European colleagues. Transaortic is not, even though it's being performed on a commercial off-label basis, it's not applicable or has not been, we're not able to use that platform quite yet. There is a portion of the transaortic which is going to be used in the partner trial under a registry for non-operative patients. So really the lion's share of procedures have been done through transfemoral and transapical techniques, and transaortic is starting to creep into it. And I think that eventually a lot of the sites have thought about in primary sternotomy patients, the transaortic may have some major play. In reduced sternotomy patients, transapical will have a major play, and of course transfemoral for us in the United States is the #1 player as far as the access site of choice.
And Professor van Ermen, what have you seen in Europe, and how do you think these new devices, the second-generation valves, are going to impact across Europe?
There's no doubt that there's another term that's creeping into medicine, and that is marketability, I think, in the 21st century. It's not only about what you can do at the level of the valve, it's about what you can sell. And for the patient, because patients, they hear, some patients, if you talk about sternotomy, they're turning around and go out of your office, and they want another approach, and there's no doubt that these new second-generation devices for the aortic valve, there's many more to come. They're going to make the access site safer, easier, smaller, with, as a result, no pain and much faster rehabilitation. And then, of course, what we should know, we can only know in 10 years from now what the durability and longevity of these different devices is going to be.
And Vinod, maybe I could ask you, I'm a surgeon, I'm very happy with the transaortic route because it's an aortic cannula, but that transapical route's a bit scary to me, and obviously you know about closure devices. How are they going to help us?
I think the transapical closure devices will change, I think, the face of transapical technology. especially when I think outside the aortic valve, but I think of the mitral valve, and I think of the new technology coming. We're going to go back towards 30 French devices. We're going to go into larger once again until we fix that technology. So I think the transapical is going to pretty much put the transapical platform, access platform, on a very much of even par, potentially with transfemoral, in the sense that anybody can do it. It doesn't require a level of expertise. The learning curve will be much shorter as far as performing the procedure. So I think it will help overall, whichever the 3-4 devices that are currently out there in humans, I think is going to be a game changer.
And you touched very gently on the mitral repair thing. Right. Professor Van Erman, you've got a lot of knowledge of this, and there's new devices out there all the time, isn't there? There's MitraClips, and then there's these new neocords and the TAC trial. How do you think that'll affect mitral repair?
As a matter of fact, if you talk about a mitral, we talk about repair in the first place, and not replacement. And then we have two distinct fields. The first one is degenerative mitral valve disease, younger people, where you absolutely have to repair. And the mitral valve being a more complex apparatus than the aortic, it's a more difficult act. And we have the type 3B patients. They come from the heart failure pool. In these patients, there's a lot of new devices, and there we have to repair, but it's not as complex. So there, for example, percutaneous acts like the MitraClip, they play a significant role already. And they're going to play an even more important role in the future, because heart failure patients, they're all over the place, many of them, and they're older and older. And we can help them with the percutaneous device, like the MitraClip. There's going to be another one, the Cardioband, soon. And these patients often had surgery already before, have calcified aorta, have bad ventricles. We'd better help them with a really less invasive procedure.
And Hendrik, what do you see perhaps as some of the problems with the mitral repair from the transapical route? What do we still need to fix to make it?
Well, my perspective is that, especially with regards to the FMR patients, who would probably be the first population we're aiming for, that probably a mitral valve replacement will be there before we have a mitral valve repair tool. It's much more difficult to develop a repair tool, since there's so many forces and so many anatomic things you have to have in mind to do so. So I'm pretty sure that the next thing we'll see on the market will be mitral valve replacement devices. And for that specific patient population, that might be a very good idea. It might also be that the results of mitral valve replacement in those patients interventionally is much better than surgically, because the risk of the procedure might be very low, and then there's a huge amount of patients out. I mean, all these patients treated now with a MitraClip could well also be treated with a mitral valve replacement device, and then have no MR anymore.
And we saw a brand new type of device, the CoreX device. This was this transapical to descending aorta, and we saw Dr. Hoffman and Dr. Billion performing this in the live surgery session. What do you think of that, Professor Van Erman?
It's not really a brand new device. The device itself exists for years and years. The new thing about it is that the fact, how do you get into the left ventricle is really easy, and they did a very smooth and superb procedure there. And there's certainly patients out there with lots of calcifications in the aortic root, with calcified aorta you cannot have access to, with bad peripheral arteries, that are major candidates for this procedure.
And Vinod, if you see a patient with a completely porcelain aorta, severe tricuspid sort of aortic stenosis, what's the best option for them, a high-risk patient?
So for those patients, we still try to go transfemoral first. If they have adequate femoral iliac vessels, then we have performed transfemoral cases in those patients. When we've gone back and looked at our data at Emory, we've noticed that the outcomes are very good and the stroke rate is exceedingly low. However, if they do not have femoral iliac access, we're unable to do them transaortic, and we're, for whatever reason, unable to do them transapically because they're, let's say, very severe COPD. We've done 5 now transcarotid valves in porcelain aortic patients with 0 stroke, and they've recovered exceedingly well with no chest tubes, or so that's the 4th option is what I consider is if you leave the other 3 out of it, the 4th option for us is transcarotid.
And I suppose something that that adds into the mix is mini AVRs. Hendrik, would you say that's almost a standard of care now, rather than stenotomy AVRs?
Well, it has to be honest, unfortunately it's not the standard of care yet, but it could be the standard of care, and if we as surgeons want to be part of the business, I think we should move there. We in Hamburg, we do every patient minimally invasive through partial stenotomy who just needs an aortic valve replacement, and that should really be the case in all the other centers too. Because it's an easy procedure, it's basically the same procedure than an open AVR, and it just needs a very steep learning curve. Maybe this can be facilitated then with the new devices we see with the sutureless valves that are now being brought to the market that help centers who have not that experience so far to open up that field.
Yeah. Professor Van Erm, have you tried these sutureless AVRs, and where do you think they sit in our armamentarium?
They sit in the armamentarium because, just as Hendrik alluded to, there's too many centers doing stenotomies yet for a very simple aortic valve replacement. And actually in those patients, they deserve to have a mini stenotomy. When I started to do mini stenotomies in '97, I was shot at. Everybody said, you don't see well enough to do an aortic valve replacement. And now everybody does that. But the sutureless valve is certainly going to facilitate a lot of surgeons doing that, because it's not always that easy to look into the root. You have to have the right approach. But if you just have to put 3 stitches and then you lower it, and for example with the intuit valve, you can inflate a balloon with a skirt that goes out to fix the valve. Sounds great.
So we've got mini AVR, we've got sutureless AVR, we've got transfemoral, transapical, transaortic, and now we've got an apical to descending aortic conduit. Vinod, I'd be able to start with you. Perhaps where is the boundaries for each patient? Where do we set them?
Of course, it depends on what your expertise is, and so you have to do what you think is you have the best outcomes with. And that's the number of thing we should concentrate on. But I think when a patient comes in to our valve clinic, we make a decision that this patient, after all the testing, will fit into which platform. And so since we are lucky enough to be able to do all the platforms, we really find and tailor the procedure for the patient. And so instead of saying, we only do transapical and that's what you're going to get, I think we just have that entire armamentarium. We do it all well. The surgeon and the cardiologist should do it well together, and we find the exact best procedure for that patient.
Professor Van Erm, where's your cutoff where you start going to transcatheter from mini AVR?
That is a very difficult question. It's about comorbidities, about calcified aorta, it's about age, and in certain sense they lower the age to patients 70-year-old. I don't think that is maybe a little bit premature. We should stick to the patient with a lot of comorbidities and high EURA scores.
I do want to comment. I'll tell you, it's interesting. If you look at the STS national database, 141,900 patients, when you break down to what is considered a high risk and not, if we take patients who are 4% or greater, it's 20% of the AVRs that are done in the United States. So 80% of AVRs done, isolated AVRs done in the United States, are an STS of less than 4. And so that was presented at the EACTS by our group, but it's looking at the entire national database. So it could be potential that 20% of the patients go towards transcatheter valve if you use STS predicted risk of mortality. The 80% become wide open for potentially minimally invasive AVRs.
Mm-hmm.
So Hendrik, you chaired the session this morning on aortic valve replacement and repair. There's totally on the other end of the spectrum, there was a brand new geometric aortic valve ring. Where do you think we are at the moment with aortic valve repair?
Yeah, unfortunately, it's been done way too less and too less numbers. I think there's high potential, and I know that a lot of insufficient valves who just have prolapse are being replaced. And since this brings a lot of problems in the younger patients, I think we should really build up an expertise in doing aortic valve repair. Unfortunately, it is a very complex procedure, so it's probably not possible that every surgeon does it. So a referring cardiologist should probably choose a center where they know where that's done perfectly and then send patients just there. On the other hand, we should really keep on doing that, because if I would be the patient, I would definitely prefer to keep my own valve. Right?
And Professor Van Erm, do you think we should have very specialized centers that just do valve repairs?
I cannot agree more, Joel. I think the time of the dinosaur cardiac surgeons, they are over. And now from very early in your training, I think, as soon as you're 30 years of age, you say, I'm going to aim for the aortic valve, or for the mitral valve, or for the aneurysms, something else. And anyhow, I think there's no way today that you can say I'm the super specialist for the reconstruction of the aortic root, and at the same time this afternoon I'm going to do a complex mitral valve repair. It is really, it's got to be something that you do just every day.
Absolutely. So one thing that's struck me, in the UK for atrial fibrillation, warfarin's been swept away with dabigatran, just gone. It's rapidly changing the field, and I know there are already studies with mechanical valves replacing, instead of warfarin, having dabigatran or an oral anticoagulant. So therefore it strikes me that a mechanical valve with dabigatran, it's not such a bad thing. How do you think that's going to change the field of aortic valve replacement? Professor Van Herman?
It's not an easy question because some surgeons now, they already have in their mind, if I put in a biological valve, I keep the possibility in 10 years from now or 12 years from now to do valve-in-valve. And I think that the market for mechanical valves is going down. Whatever new anticoagulant treatment is going to come on the market, I don't see a big increase anymore in mechanical valves. More and more, if you operate on patients in a young age, what they want to do, they do want to do mountain biking and skiing, and that's not the moment where you want to be on anticoagulants.
And Vinod, do you think it'll be dabigatran mechanical or just a valve-in-valve in 10 years' time?
I think that it'll be valve-in-valve. And I think that, our cardiologists, when they refer patients to us, they're specifically saying, don't put a mechanical valve in this patient, because I know that down the road, you'll do a valve-in-valve in this patient. Just put a big valve in so that you can do the valve-in-valve. And so I think I agree with you, Professor, that's exactly what I foresee also happening in the U.S.
There's probably one thing we have to have in mind with regards to that, is that we should go for larger valves to have the chance to do valve-in-valve. And I know so many surgeons who have no problem implanting a 21 valve in a larger person. That may go well at that very point of surgery, but then 10 years after, there's no chance to put a valve-in-valve procedure in there. So I would rather go for a root enlargement and do a meningioplasty and then implant a larger size valve. That's much more sensible for the patients in the long run. So we keep that in mind as surgeons.
The gradients have been relatively high, even in 21 valves, and so even in 23 valves, 23 inside of 23, hasn't had great gradients with that.
And we should always remember that the inner diameter of these valves is much different from what's written on the package, right? It's very
That's
very
exactly
different.
what industry should look at now. They should make valves that are ready to receive a new one inside. And then we have to aim for bigger valves, no doubt. But if the industry keeps in mind that this is going to be a valve that later on they want to do valve-in-valve in, the valve that we do you valve-in-valve in today, they were not designed with that in mind.
Well, I think that's a great point to finish with the future. And I'd just like to say for myself, Joel Dunning, thank you very much, Vinod Tarani, Hugo Van Herman, and Hendrik Trieder. Thank you very much for coming, and thank you all for watching.